morning. Good morning. Good morning. Thank you. So this is one of those lighting setups that is really blinding. So I'm going to just proceed with the expectation that everybody is sitting in their seats, enjoying their breakfast, and paying rapt attention. Really want to extend a very warm welcome to the ITUP Annual Conference, the first one we've been able to have in person for 3 years, since 2020. We are really delighted to be back together again with such a great community of interest around the issues of access to care and coverage, equity, quality, all those values that we care so much about. I also want to extend a warm welcome to people who are participating virtually around the state or outside of the state. We are, again, really pleased to be able to offer both in-person and virtual access to this conference. I'm Marian Mulkey. I'm the chair of the Insure the Uninsured Project's Board of Directors, ITUP, as we call it affectionately, and I'm currently also serving as the ITUP Interim Executive Director. I'm really delighted to welcome you all here on these important conversations about cultivating an equitable health future for all Californians. Today's event is going to showcase the innovative, forward-thinking leaders and work that California is known for, while also acknowledging that work remains to be done to create the healthcare system that we all want, that truly works for all Californians. I want to start by thanking the ITUP staff for putting together this amazing event. More than ever this year, I have benefited from the opportunity to see a little bit behind the scenes and recognize just what a fantastically dedicated and capable team we have. I hope you will all thank them as well when you see them at the table in the lobby or otherwise. This is me. I have now caught up. I want to express our gratitude also to our conference sponsors, especially our gold event sponsors, Anthem Blue Cross and Kaiser Permanente, for making sure that this signature event continues again this year. We encourage you to visit all our supporter booths set up in the lobby during the breaks and throughout the conference to connect with our event supporters, who we do truly appreciate. ITUP's broader work is funded by 3 core funders: the California Healthcare Foundation, the California Endowment, and the California Wellness Foundation. We thank them deeply as well for their ongoing support, especially during times of uncertainty and transition. That's them again. Before we get started, I also wanted to give a deep and warm welcome to anybody who may be here for the first time or who in the 3 years since we last met together might need a little refreshing on who ITUP is. So a little bit of brief background. ITUP is a 27-year-old health policy nonprofit and convener. In addition to this annual conference, we also run more than a dozen policy and regional work groups across the state each year. We produce in-depth issue briefs and high-level fact sheets to inform those developing health policy, either through legislative or administrative action, as well as to inform those who are responsible for taking the policy really through on real-world implementation. At ITUP, we have 3 key focus areas: coverage and access, which is in keeping with our founding goal of insuring the uninsured; delivery system transformation; and the future of health. And on all of those, we are increasingly focused on equitable outcomes across California's diverse communities. The mission of ITUP is to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. ITUP implements its mission through policy-focused research and broad-based stakeholder engagement. We do believe that all Californians should have a fair opportunity to live their healthiest lives, and like so many of you, seek a healthcare system that's universal, equitable, accessible, effective, and affordable. As an independent nonprofit organization dedicated to improving the health of Californians, ITUP's views are its own. Now, just a few reminders, the logistics housekeeping part of the agenda. Please turn your cell phones to silent. There is complimentary Wi-Fi, and you can access it using the network and password instructions on this screen. Okay, this is the nitty-gritty here. So hopefully many of you have already downloaded the conference app, but that's the way to access the agenda, to give us feedback through evaluations, and otherwise get updates about the conference. So to get that, you need to download it at your favorite app store, wherever you get your apps. Expo Pass is the name of the app. Once you've downloaded it, open the mobile app, click Log On, and at the same time having trouble logging in, and then you enter the same email that you used to register. It needs to be the same one, not your other home email or whatever it might be, and click Send Magic Link. Don't we all wish we had magic links? So, again, stick with the email you used. In the email that you will then get from expocent.com, verify your email by clicking the teal mobile magic link button. The app should open. You should see information about this conference, and you should be all set. But if at any time you need assistance, the terrific staff at the ITUP help desks will be happy to assist. All right. This is the fun, I hope, aspect, or one fun aspect of the day, to keep us all engaged and offer a little bit of additional incentive for you to stay with us through the whole day. We have a raffle prize. Anyone who has registered for the conference and remains here through the conclusion of the event will be eligible to win one of two $150 Visa gift cards. And for those joining virtually, there is an opportunity as well to participate. View the web app to learn more. All right, so a quick overview of today's agenda. You can access the whole exciting agenda either by viewing it via the conference app or by scanning the QR code on your badge. Today's events will begin with an acknowledgement of California's historic health coverage achievements and a look toward what California healthcare leaders are tackling next. These conversations are followed by spotlighting how broadband and connectivity are essential to getting all California's healthcare when and how they need it. Following those morning plenaries, we're pleased to have carved out time for a network lunch without scheduled speakers. For those of you who have been at ITUP for a long time, you know that that hasn't always been our approach, but we're really glad to leave a little space for you to get to know one another and to reconnect during that lunch period. Then this afternoon, we have 2 rounds of thought-provoking breakout sessions planned. These dive deeper into pressing healthcare needs and emerging solutions in California's communities. These conversations will center around healthcare innovation, around individual and community needs, persistently asking the questions, are we making healthcare better, more accessible and equitable, and for whom? The first set of breakout sessions brings the perspectives of key population segments, older adults, farm workers, and the unhoused communities. The second set tackles several barriers to quality, accessible, and equitable health care, specifically workforce challenges, data exchange needs, systemic racism in healthcare, and virtual care. And so I really hope that, like me, you will find an abundance of riches. I think there's something to interest almost all of us, and the challenge may be deciding which of these great sessions you want to spend your time with. We do hope that you'll stay all the way through the end of today's agenda to hear a classic ITUP conversation among state healthcare leaders. And then finally, we will close out with a keynote session from Federal Center for Medicare and Medicaid Services Deputy Administrator and Director Daniel Tsai on opportunities that lie ahead for Medi-Cal and the path to a more equitable healthcare system. So now that we have looked at what you can expect for the rest of the day, I have a final and exciting announcement, which was previewed for many of you at last night's dinner, about what you can expect from ITUP in the time ahead. As I said, I've been serving as interim executive director for the past 3 months following the departure of our previous executive director, Katie Hydorn. to accept a new role. And during that time, the ITUP Board of Directors engaged in a thorough, thoughtful search for our next executive director. We are thrilled to announce our decision, which is shown here. Our incoming executive director, Crispin Delgado, is a seasoned philanthropic and policy professional who's worked to advance value-based care in California in roles at Blue Shield of California and in the San Mateo County Safety Net. Comes to ITUP from his current role as Public Policy Director of Northern California Grantmakers, where he has worked on strategy and priorities related to the COVID-19 recovery, strengthening democracy, and expanding access to health care. So please join me again in welcoming. Crispin's going to share just a few remarks with us before we kick the day off further.
Good morning, everyone. I first want to thank the board for trusting me in taking over this role as Executive Director of ITUP. I'm both excited and humbled. I'm the child and grandchild of immigrants that came to this country for a better life, for the future generation that included me. I was born into the safety net. I was born in a community hospital in Richmond, California. I did all my first checkups at a community health center in Richmond. And despite the challenges of growing up in this community, I was fortunate enough to be the first person in my family of all generations in the United States to go to college. And so I wanted to pursue a degree to help others like my family, whether immigrants with health coverage or thinking about people on the front lines. UC Davis offered me a different environment that took some adjustment, but it also was my first taste of being politically involved. I joined UC Davis at a time when we were debating Props 187 or trying to eliminate bilingual education, ending affirmative action. And so for me, it was a wake-up call of having to use my voice to create change for people that look like me. From there, I was lucky enough to get a full ride to the Goldman School of Public Policy at UC Berkeley. And so I pursued my master's in public policy with a focus on public health. And so, now I've spent the last 20 plus years working in academia, local government, philanthropy, and consulting, all in service of improving access to and quality of healthcare for all Californians. I believe in our lifetimes, there is something profound that makes us pause and understand the magnitude of reality. For me, this was COVID-19. Why, you must ask? I felt compelled to act because I just saw so many families being destroyed by this virus. As of yesterday, there were over 103,000 Californians that have lost their lives. And I also recognize that with the pandemic, communities of color and low-income communities were hit first and hit hardest. And in looking at the data and employing a lot of what I learned throughout my career, it was important that we looked at occupation, so who were the essential workers, what was the risk for exposure, but also looking at race and place data, and really using data to make data-informed decisions on strategy of how to reach those communities that needed the most help. And to be honest, a lot of the communities that were hit first and hardest will also take the longest to recover. So we mustn't just walk away from this work because we understand that there are still people that are vulnerable. For the past 3 years as Public Policy Director at Northern California Grantmakers, I had the opportunity to learn more, have more tools to advance equity. And so I'm looking forward to bringing that into this new role. And so As I reflect on the impact of COVID-19 on California, I understand, especially for our healthcare workers, that burnout is real. It required so much of our healthcare industry to support families and communities through the pandemic. And at the same time, we're also looking to grapple with some transformational changes that are needed in the sector. And so while some policymakers have claimed that the pandemic is over, we now have to get a better sense of what it is to get back to normalcy and redefine what normal is. So whether, for the families that have suffered from COVID, they might still be dealing with being unable to smell, and others are dealing with the emotional impact of having an empty chair at their dinner table. And so this is what's happening now, and it'll continue tomorrow. And so it's not business as usual, but when I think about ITUP and what ITUP is known for convening, for bringing people together, for putting research out, I'm committed to continuing that work. And at the same time, I see it as an opportunity to advance racial equity. I'm the first executive director of color, and I'm very proud of that. And I hope that bringing my experiences and my background, that I can really advance equity, health equity in California with all of you. So thank you again to the board and to the staff for putting this together. And thank you. I look forward to meeting you.
I neglected to say in my enthusiasm for bringing Crispin on board that he has not actually officially started yet. His start date is March 20th, but please get to know him during this time he's given to us this conference and very soon as he joins us fully. So my next great honor is to introduce Secretary of the California Health and Human Services Agency, Dr. Mark Ghaly, who's going to provide us with some opening remarks. Dr. Ghaly was appointed secretary by Governor Gavin Newsom in 2019. In this role, Dr. Ghaly oversees California's largest agency with 12 departments and several offices. His accomplishments and impact as secretary are genuinely far too numerous to list, but a very incomplete list includes the grace and determination with which he supported the governor in navigating the COVID-19 pandemic, his leadership on the state's master plan on aging, his clear commitment to extend meaningful coverage and high-quality care via both the Medi-Cal program and as on his role as chair of the Board of Covered California, and his deep passion to improve youth behavioral health. So, Secretary Ghaly, Mark, we are so glad to have you.
Good morning. What honor to be here. It's fun to look around the room. Actually, the glare is pretty intense up here, but beforehand, I had a chance to see many faces that I hadn't had a chance to see in quite some time. Crispin, great to meet you. Congratulations. It sounds like a terrific choice for ITUP and really signifies not just a changing of the guard, but I think a real interest in changing the mission and the approach. And I'm excited to share a few thoughts on that as we continue to navigate and cultivate, as the conference title shares that name, what we're doing here in California. So I'll just take about 10 or 15 minutes to open us up. Excited for the panels that will come next, and really looking forward to hearing what Dan has to say about how we continue to use Medicaid as one of the most important equity tools, health or otherwise, that we have available to us. And it's also terrific to see just the broad range of individuals, not just in the health sector, but Kathy, great to see you here with CWDA and representing not just that work that's important on Medicaid and redetermination and determination and eligibility, but the whole coupling of health and human services, which has been a really deep part of our agency's mission, not just because of the pandemic, but integrating well before then. Do I advance these few slides? Can you see them? You can. Okay. I cannot. Now I can. Okay. So just quickly, this is a slide that I feel like we show every time the secretary stands up at this dais and talks about, look back, 2013, 2014, 17+% of Californians uninsured, uncovered, and, sorry, go back. Now they're flipping through. There we go. That we started at quite a deficit, I mean, above the national figures of where the uninsured stood in many other states. And then California is embracing, under now multiple governors, the Affordable Care Act and the opportunity to get folks into what is the nation's best exchange and strongest effort at Covered California. I know you'll hear from Jessica as part of this day's conversation, but also that expansion of Medicaid in ways that were obvious to many early, not obvious the path there, thanks to many folks in this room for their championing that progress with Medicaid expansion. But today, to expand not just to the eligible populations at the federal level, but to really have state-based efforts to add little by little, year over year, hopefully culminating in next year's commitment to make sure that all Californians, regardless of documentation status, who are eligible for Medicaid do get access to that. And I think we celebrate that on a regular basis, but that is worth a big applause. Because not only is that sort of first in the nation stuff, but it is exactly for families like yours that you described and millions of other Californians really access to the California for All and the dream. And I know Governor Newsom very proud of protecting that despite the ups and downs with budgets, that this is something we're committed to seeing through. Proud of the team at DHCS, proud of the team in this room, not just within California state government, that are making that dream possible. You also know that there's been quite a significant investment, not just in the coverage side of Medicaid, but in the actual fiscal investment. And I said at our January governor proposed budget presentation that we've increased the HHS budget by over 40% in just the last 4 years. If you look at the Medicaid investment, it's actually a 66% increase in funding in the Medicaid program in that same period of time. So Governor Newsom, Governor Newsom came in committed to focusing on the Medicaid program, focusing on the behavioral health parts of that, focusing on an idea that has become CalAIM. And I think the investments, budget over budget, through the pandemic demonstrate that in many ways. But we know that it's not just about coverage, it's not just about the investments, but so many other things as well. So we have set out at Cal HHS to set some really bold guiding principles and priorities. And I think if there's a single word that guides that, I would say it is equity. And what do we mean by equity? I think it's worth just a moment defining it. It's really focused on changing that power imbalance that we see in so many of the systems. I think, Marion, I think back to the work we did on the commission, the Healthy California for All Commission, some of the members here. There was a small piece of it that, frankly, I carry with me throughout my thinking and travels in health. Came at the benefit of 3 of our philanthropic members. They convened, and I saw Karen and some of the other folks who actually did the work as part of that, and Dr. Hernandez is on, looks like, the next panel, but really asking what do Californians that really often are overlooked. And on the outside of healthcare, those that we've been working hard to cover, what do they think equity means for them in getting covered? And it really meant a couple of things in that work. It was that we need to make sure that they're part of the conversation and at the table designing the system. Some of us talk about that as empowerment. I talk about that as let's shift the power dynamic in real ways. I'm proud of the work that DHCS is doing in that space under Director Boss's leadership, really engaging and communicating more with communities, understanding through their listening tour, visiting county after county, getting into the nooks and crannies of our neighborhoods to understand what is working and what isn't with the care people are receiving. And then the second thing that was demanded, frankly, out of those conversations was simplicity. We make this super complicated for people, and no place more is that true than behavioral health. And I think even the most well-equipped, well-meaned person has challenges with behavioral health. And if we're going to deliver on equity, it needs to have people empowered in the middle of it. But secondly, we have to simplify this whole mess that we call healthcare in California. So some of the ways that we're focusing on equity and quality is these important efforts that you see up on the screen. I think the standard health equity and quality measures that both DMHC are pushing forward, but also that comprehensive quality strategy that DHCS has moved forward and committed to by 2025, cutting some of our challenges in whether it's maternal health, behavioral health integration, or children's preventative services by 50%. So real meaningful, tangible improvement in some areas that sadly California has lagged behind so many other states. And that improvement isn't just for bragging rights, although that always feels good, but really because that's what's going to move our communities forward. The work we've done with gender-affirming care and the requirements that DMHC is putting in place to ensure that health plans meet certain standards, have provider networks that are focused on LGBTQ populations, that the wide range of services that we know communities need are available. That work in the contracts for Medicaid that we hope and expect to take shape next year. I know a lot of people were excited, interested, kind of went on the roller coaster ride of what this procurement that just closed up, how it would end. But the bottom line to us was the contracts and moving into those contracts was the most important thing for us to realize, and that work is starting now with the health plans that we've agreed to work with, but not just those on the commercial side, but all the local initiative plans, also having much more, I would say, ambitious, bold requirements for how we engage community, which groups within the county you must work with, the focus on working with your sheriff department, your probation department, your child welfare department, working closely with those homeless services providers that are often figuring out how they partake in this whole structure of Medicaid. I think a lot of exciting things to come. And then we know, and I appreciate the reference to the pandemic, which we're not through it. It's still something that affects thousands of Californians on a daily basis. The loss of loved ones, the impact of long COVID, the truth and reality of what we're facing, family, community, county, state, all together. It's still important, and even as the numbers come down in terms of infections and hospitalizations, the reeling within those households, as you eloquently said, Crispin, that the health system's recovery from some of these challenges, we see it today, the workforce. I was with group of providers just yesterday listening to the challenges in recruiting and affording the workforce today, whether that's nurses or techs or even physicians. And we know it all too well on the behavioral health side, but even on the physical health side, it's very vulnerable at the moment, and we have our work cut out for us. So working everything from the inpatient facilities to the skilled nursing facilities to strengthening our community provider network, whether it's FQHCs or small independent practices to thrive. We need them. We can't realize the benefit of all the hard work on coverage unless those provider groups are supported to do the work that I know many of us want to see them do. Just want to take a moment, and I spoke at the beginning about the need to integrate health and human services, which is something we continue to work hard on. I know later today you'll have a chance to hear from John Ohanian about this really critical work. I don't think it's overlooked anymore. I think it's front and center for many people. We just passed a very important milestone on this map, which was that the required entities who were meant to sign the agreement to share data in a timely way with one another through this data exchange framework. That passed. We're still working on getting many of those entities comfortable with signing, but let's just fast forward to next year and over the next couple of years to becoming a state where that health and that human services data is available not just at the sort of the high planning level, but at the individual care level. And that I know in my days struggling to take care of patients, whether it was in Bayview Hunters Point in San Francisco or in South Los Angeles at MLK, the inability to see what happened to individuals who, because they didn't have a regular source of care, because some of the facilities in their communities had closed or restructured over the years, that information was missing and we couldn't do as good a job as we wanted to take care of that individual. Or the fact that we talk about empowerment and equity. How can you feel empowered when half of the information about what's happened to you recently is missing and not together? So this effort around data exchange, I think, really propels us forward into a place where so many other states are already sort of experiencing the benefit. And we have this opportunity to couple these transformations that I've highlighted with the real, meat and potatoes of the work in making sure that individuals' information is available and actionable, not just by the systems that care for them, but by they themselves. And I look forward to John's presentation later on in today's session. So Marion and I have had a few spirited conversations about ITUP's mission and the focus on coverage. And I think it's been such an appropriate focus, especially when you go back to that first slide, the sort of tried and true traditional slide of showing how many great steps we've taken to increase coverage. But as we really think about what is next and how do we make our work around quality and access even more front and center, even more meaningful than it's been because of the achievements we've made on coverage, I think it's really important to turn to two words that we often say, but we don't always think about how we implement them in transparency and accountability. And so this last year, either DMHC or DHCS has really pushed forward, I think, very tangible, palpable for some, because it affected the pocketbook of some plans, issues around transparency and accountability. And if you look at the new 2024 managed care contracts, one of the most important pieces that you should find in it is a requirement that plans are transparent and reporting data, not just to the state, but in ways that beneficiaries actually, if we do succeed in creating a truly empowered set of community members, they're going to have choices. They're going to see information and they're going to vote with their feet because neighbors and their experience with the plan and They'll see information, hopefully, in easily translatable ways that we hope is going to affect where people choose to get their care, the systems that they vote for. And in doing that, we think we're going to be able to push the quality of care even further. So in the vein of that concept of cultivating, I think this work around transparency and accountability is starting. We're going to see its fruits over the next couple of years. And I hope as we stand here next year and the year after that we'll see not only have we made these tremendous coverage gains, but we've done an incredible job on pushing quality and pushing access as well. So I wanted to wrap up with this last slide. And when I think about where the system is really challenged today and where the work of cultivating projects, ideas, investments today really can and will pay off, I think about behavioral health. And this list of efforts, I think, just begin to underscore the investments made by the administration in behavioral health, the focus on those who are experiencing crisis, the CARE Act focus on individuals who often suffer from the most severe and often untreated behavioral health conditions, the opportunity to add peers and other recovery services to what Medicaid provides, the whole work that we're going to be doing on mobile crisis, the CalAIM community supports, of which many of the 14 available focus on behavioral health, help think about where we can go in this space. The work that we have been doing and will continue to do with counties on transforming how behavioral health is paid for, the integration between the responsibility of mild to moderate over here and severe and persistent over there. How do we bring that more closely together? But I also see one of the most important newish frontiers is the work that DMHC has started to do and will continue to do to push and hold accountable, that word again, accountable, the commercial behavioral health system. And I believe that if we're going to have the kind of success that we want to see in the public safety nets behavioral health system, that county-operated behavioral health system, even though we need to push there and be thoughtful around where that goes, we have to make sure that we turn some of our focus to that commercial side of the work. And I have stood now probably over the last few weeks in rooms with elected leaders and community members alike who, with their coverage, feel like they have nowhere to go on behavioral health. Some of the most powerful Californians have stood up and say, I don't know where to get care. I'm covered, but I don't really know how to navigate this behavioral health system. And I spend so much of my time focusing on the safety net part of the system and not enough time on the other. And my commitment is to join many of you in focusing there more and more. I'm proud of the work that Mary and her team are doing at DMHC, but we have a long way to go. And if this system's ever going to feel truly integrated across payer lines, across Medicaid and the commercial side, we have our work cut out for us. But I think as ITOP considers where to go next, really sets out a different course. I think the focus on how we turn that coverage into meaningful access, not on just the health side, but the behavioral health side, will continue to be important. I know I said I would wrap up, but this is the last thing I'll say because, David, you're right in my front view. 2 weeks ago, I would say one of the most important parts of the CalAIM plan was approved by the federal government, and I think this is worth, for all of us who've said, how do we make coverage available broadly to not just people in the Medicaid program, but even broader? We started to chip away at something known as the inmate exclusion through the CalAIM Justice Initiative, which provides for the first time a state permission to serve individuals who are Medicaid beneficiaries or eligible within incarcerated settings, so jails, prisons, and juvenile detention facilities with up to 90 days. We started at 30, California pushed for 90, and we got 90 to not just provide the care and services that they need, that individuals need as they're exiting, but also to do that important work of handing people off, making sure they transition well. So when we think about expanding coverage to that population that so long has been overlooked, I'm really proud of California's work and leadership in that space. So Marion, I'm sure I went over time, but I appreciate everyone's time and enthusiasm for the work ahead as we cultivate a healthier California for all.
Thank you so much, Secretary Galley. And again, we just so appreciate your commitment to the work of making our whole state healthier and safe. So let me invite our next panel right up. I think we're all here. We're really delighted to take on this topic of California's culture of coverage, which some of us were reflecting last night is a term that we've thrown around for a while and maybe have seen more fully realized at some points than others. But this is a year where we are closer than we've ever been, and we have a terrific panel of folks who can both, I think, celebrate our accomplishments and talk about maybe a little bit of remaining work to be done. So I have the great honor of introducing our moderator for this panel, Dr. Sandra Hernandez, who is, as many of you well know, the president and CEO of the California Healthcare Foundation. Prior to joining CHCF, Sandra was CEO of the San Francisco Foundation for 16 years, and prior to that served as Director of Public Health for the City and County of San Francisco. So deep and broad experience, and also a fantastic facilitator of this esteemed panel. So Sandra, please take it away, and thank you all for being with us.
Thank you, Marianne. Good morning, everybody. Let me first begin by congratulating the Board of ITUP on hiring Crispin. So welcome, Crispin, to you, and we look forward to working with you. So welcome. I think the panel needs hardly any introductions. They're in your brochures. All of them are colleagues and friends and people, I think, who have been working at the mission of ITUP probably for most of their careers. So I'm not going to spend a lot of time on that. I do want to reflect on sort of where we are at a moment in time. And Secretary Galley gave, of course, beautiful remarks in that regard. But it does sort of feel like we're at a moment where the pandemic really accelerated a lot of both opportunities and, of course, really a lot of extraordinary challenges for our delivery system. And it's important to celebrate where we are on coverage. I remember meeting Lucian many moons ago when it was a project to insure the uninsured. And so to take a moment and just reflect on Secretary Galley's comments over the expansion of Medicaid and Medi-Cal in California, really the journey of implementing ACA over the last 10 years, California clearly was the lead train in that, both through Covered California and through Medicaid expansion. And with the public health emergency now looking at waning, the whole effort at making sure we don't lose the incredible coverage we gained during the pandemic, but also making sure the folks that we have yet to reach and get into our Medicaid program, that we sort of use this moment in time to finish the work of that project. And then lastly, I would just want to say that we've also been on this incredible journey to reform our healthcare delivery system. And as Secretary Galley mentioned, Medicaid should be a tool for equity. And so I think we're at a moment where we're shifting from a culture of coverage, not quite done, but almost done, to a culture of equity. And what does that look like, and how do we get there? So that's the conversation I'm hoping to engage my colleagues on today. Let me just start with coverage and health care for all. And maybe, Anthony, if I could ask you You've been a longtime champion of healthcare for all. Today, what do you think about what's top of mind for you on finishing the journey to coverage in California?
So, thank you, Sandra. Good morning, everybody.
Good morning.
Yeah, it's good to see everybody. See some of you in person for the first time in maybe 2 or 3 years. So, just want to acknowledge that. Again, my name is Anthony Wright. I'm the Executive Director of Health Access California, the statewide healthcare consumer advocacy coalition. And we've been really proud of the work that California has done to both implement and improve upon the Affordable Care Act, to take those proactive steps to really deal with that chart that Secretary Galley talked about, where we were literally had one of the highest uninsured rates in the nation, over 7 million people, and the work that we've done to chip away at it. And I know that everybody wants to talk about what's next, what's the next thing. And, to be honest, we're all in on that agenda, the quality and equity agenda, holding the industry accountable for quality, and whether it's as a purchaser through the Medi-Cal contracts, Covered California attachments, or through the regulatory power, the new DMHC regulations, et cetera, or all the other work we're doing. But I do want us to not lose focus on finishing the job on coverage. We still have more to do. California, with all the progress we made that we should be so proud of, still has more uninsured people than most states have people. We still have a couple million folks, and there are still things that we need to do to move forward. So whether it's, the work of just getting what was committed to, not just signed, but started with regard to the Medi-Cal expansion in January 2024 that will cover over 700,000 additional Californians, regardless of immigration status. That is a big, big deal. That is worthy of our continued fighting, especially in maybe economically questionable times, that we make sure that there is a commitment there. It also means taking the next step with regard to Covered California and removing the exclusion that exists there. We tried that once. We've applied for a waiver from the federal government in 2016. We withdrew it on January 19th, 2017 for obvious reasons of the change of the federal government, but we need to revisit that. And some states have actually moved ahead on this. Colorado has started enrolling people in their exchange. Washington just got a waiver. So I just say that to stir up some of the competitive juices in this California crowd. I think, so we have more to do, and frankly, we have more to do on affordability. And also, we need a coverage that is accessible, affordable, and also, as Dr. Galley said, administratively simple. Even if we get to the world where everybody's eligible for something, then we need to switch the incentives of the system where the burden of enrollment is on the system rather than the individual. And, and we've taken some last year we had bills on making it easier to sign up for coverage when you file your taxes, when you file for unemployment insurance, even when you go on strike. But we need to take this on in a much more comprehensive way to really make this a seamless system. And there's no better place to start than with the public health unwinding and, that gargantuan challenge I know Kathy and others will talk about to make sure that people are not losing coverage as the public health emergency unwinds. But I do want to come back to affordability because that is so fundamental. Even if you remove the explicit exclusions of some of our brothers and neighbors and community members, even if you make it easier, at the end of the day, affordability is key. And that's we made a big contribution to the federal debate with increasing subsidies in Covered California, state-based subsidies, and that became national with the American Rescue Plan and the Inflation Reduction Act, which has now extended coverage. And we should acknowledge this. Right now, nobody has to pay more than 8% of their income for coverage, regardless of their income, regardless of their circumstance. That is what that Federal Inflation Reduction Act extended for multiple more years. And so we think there's an opportunity to also then look at the additional affordability barriers of cost sharing. In covered California, what you're subsidized for is a silver plan that has a nearly $5,000 hospital deductible. And that is off-putting to many. Most people don't have that kind of money in the bank. And we can use the dollars that was raised from the individual mandate that we had go to our state subsidy program, but has now been supplanted by the federal government. We can use those dollars to eliminate that deductible and also reduce cost sharing in covered California. We also need to extend the copay cap on prescription drugs this year. But we need to deal with the base cost of coverage. And so my final comments, because access and affordability are so intertwined, is how to deal with these broader questions. And I'm glad what the governor is doing with regard to prescription drugs. And we're very excited about the new start of an Office of Healthcare Affordability that will set a target for the industry with regard to cost growth, because we're never going to meet a goal we don't set and have that target be enforceable. And we need to deal with some of the other sort of incentives of why healthcare prices are so high. One of the major drivers of that is consolidation. And so one of the big pushes this year will be to try to increase the Attorney General oversight over mergers and consolidation in the health industry. In a further conversation, I want to talk about consumer protection, but I want to just preemptively endorse much of what my colleagues will say on quality and equity and consumer protection, but I just want to say let's not forget about coverage, and let's make sure that we focus on cost, which is the barrier that so many Californians face right now.
Yeah, thank you, Anthony, for naming that. And Secretary Galley did talk about the survey we did for Healthcare for All with consumers and low-income folks, and affordability was also one of the themes we heard from the nonprofits and the various listening efforts that we did as part of Healthcare for All. So affordability is definitely an issue. Kathy, I want to come to you. You will be, your organization and folks will be on the ground on redetermination, been working with the HCS. Would love to know your thoughts, how it's going, what some of the opportunities and challenges are.
Sure, absolutely. Hi, everybody. It's great to see so many people. CWDA, of course, represents all 58 county human services agencies. And in addition to the Medi-Cal eligibility, we also run the other safety net programs, child welfare, adult protection, in-home supportive services. And so really, I think everything that Dr. Galley was talking about, everything that Anthony's talked about, touches not just us on the ground as the sort of administrators or gatekeepers of care, but also the people that we're serving. You know, families getting coverage through their CalWORKs, children in foster care who need behavioral health. So it all really speaks to us, though, of course, the question of the hour is, how's it going as you prep for the unwinding of the continuous coverage provisions? So I'll focus my initial remarks there. So I think when everything, I mean, it's been almost exactly 3 years, right, when this all sort of initially hit with the pandemic and we locked down, and then very quickly after that, the continuous coverage provisions were put into place by the federal government. We really started planning for the end of that as soon as it started, because we didn't know how long it was going to be. I mean, I didn't really think, did any of us think that we'd be sitting here 3 years later talking about the unwinding, still, many of us wearing masks or debating whether to wear a mask or feeling guilty if we didn't wear a mask, et cetera. And I think that, so what's been great about that is that we've been talking about it with Department of Healthcare Services, with advocacy organizations that we partner closely with, just internally in board meetings, in meetings of our medical care and self-sufficiency committees, which are our leaders in these programs, for going on 3 years. So we've known there were going to be some things to watch out for, some things to take into consideration, and that we wanted to have automation to support that as much as possible. So I do feel like we're, if anyone or any system can be set up as well as possible for dealing with 16 million enrollees needing to go through a redetermination process over a 14-month period, which is what we're looking at. I think we're as set up as anyone can be. I think we're going to talk a little bit later about some of the workforce challenges. Yep. And I'll just say in a nutshell, absolutely counties and county human services are experiencing workforce issues and labor shortages just like everyone else in every sector is. But we're hiring and we're training the heck out of our new hires and our existing staff as well. We have many people who've joined relatively recently to the county and have never actually processed a redetermination packet. But it's really important to know that we didn't just stop doing redeterminations at all as a system when that continuous coverage provision went into effect. Our computer system, the SAWS system, starts that process 90 days in advance of someone's eligibility renewal being due. And it starts out with an ex parte automated process where we see, can we find Anthony Wright continued for his eligibility, and if we're able to do that, and we refer to that internally as the happy path, if Anthony's on the happy path, even for the last 3 years, he would still get a letter saying, congratulations, we found you still eligible. And so we've rolled forward some percentage of people. It's not like we've had people just sitting there and absolutely nothing's happened. And so I think that's a helpful thing to know. It's not like we're restarting the processing of paperwork for people for whom that happy path didn't happen. They didn't need to send it back, and if they sent it back, we didn't really pay very much attention to it. We did make changes that were helpful to people. Somebody had a baby, great, we added them. I mean, things like that. And that would also set their dates forward. Remember, the Affordable Care Act made a lot of changes in how we run our system. And when you find someone is still eligible after looking at a change in their case, you're actually able to roll their date forward by 12 months. So we've got some percentage of our caseload that has been found eligible more recently, that has been rolled forward. And so really, I think what we're thinking about now is a couple of things, and then I'll pass the mic back figuratively to continue the conversation. We are thinking about messaging, because we've got a lot of folks who got those packets and we're told, don't worry about them. You know, you don't have to send that back. Everybody's got coverage, just ignore it. Or they sent it back and we ignored it. And so people do really need to know now that when they get something, if they get something in the next year, year and a half, they need to open that, read it, and pay attention to it at this point. Now is the time we sort of need to send those messages, as well as ensuring that as we're getting that information back from people, we're able to connect to them at their appropriate contact information. I think a lot of folks in this room, how many people have heard, tell everybody to call, make sure your address is right, make sure your phone number is right. Well, I would just say yes, except only if it's changed. If that person has been getting, packets or letters, things from the county for the last 3 years, you're good. We know where you are. It's okay. Every single person on Medi-Cal does not need to call their worker right now. And that's an important nuance to the message. So I think working together both locally and at a state level with DHCS, with everybody in this room, with the plans, just even yesterday we got an email at the office. I have a client who's a large health company that would like to help. And I was like, okay, how do they think they're going to help? I need to explain to you how this all works. So we're going to have a lot of conversations like that with folks to make sure that we're all talking off the same page and that we can get as much help as possible while also not scaring people, not making people worry that they're missing something that maybe they haven't gotten yet or that they may never get as far as a packet if, like Anthony, my friend here, they're on the happy path and we found them eligible. So definitely reminding everybody of the nuances of our system and how it's not exactly the same for everyone, which doesn't make it all that simple, but can really make it work for people when we remind them of that, I think. So, but we'll start there.
Let's go a little deeper into care. Karen, you were part of the effort that Secretary Galley referenced as we talked to low-income Californians. And I wonder, one of the big takeaways, in addition to affordability and simplicity, was the notion of cultural humility and respect. And CPEN, of course, has been a huge advocate for addressing structural racism in our delivery system. And so I'm wondering, what are you thinking about today as we're moving out of the emergency, moving into recertification, and really trying to get people into culturally appropriate, respectful, whole person, fully integrated care. Karen.
Great. Thank you so much, Sandra. And thanks to ITUP for the invitation to be here, and also to my colleagues on this panel who are real partners, I think, when we think about advancing equity. I want to start just really quickly by grounding us in where health equity and particularly racial equity stands today. And I really appreciate and couldn't be more proud of our state for all the work that the Secretary outlined around equity. That wasn't the case 5 years ago, right? And so really excited about where we are today. But also really want to recognize that our racial disparities are deeply entrenched and, to be frank, haven't budged even over the last 5 years. The ACA, the great slide was up there, really made a dent in our coverage gaps for people of color. People of color benefited immensely from the ACA. Will continue to benefit from the Medicaid expansion in 2024 here in California for the undocumented. But at the same time, these increased rates of coverage have not fully translated into improved health outcomes. As many people know, in 2020, during the height of the pandemic, U.S. life expectancy experienced the largest single-year decline in at least 40 years. But this was not born equally. Black and Latino populations experienced reductions in life expectancy at birth that were over twice as large as that of the white population. And I think even more alarmingly to me, this trend has continued into 2021. Our recent research shows even once we had COVID vaccines available, we continue to see, in California specifically, the decrease in life expectancy and the widening of disparities continue. So we have a lot of work to do, and sort of to answer the question about, what we're thinking about and where we're hoping to go, I just want to outline a few areas of focus for us. So one is paying for equity. Equity is not free, equity is not cheap, and payment reform must be strongly tied to the attainment of equity and disparities reduction goals. We're really excited that major purchasers in this state, Medi-Cal, Covered California, CalPERS, are moving in this direction, but the dollars we put towards those efforts must be sufficient to drive change, and we need to use both carrots and sticks, or both incentives and penalties, to really drive performance improvement and disparities reduction. Second, the Secretary talked a lot about empowerment and shifting power. And we really think that equity is fundamentally about power. It's about who has power and who doesn't have power. And this is particularly salient in health equity, where people of color have often faced systemic barriers to having power over their own health, but also barriers to having a voice in the design of the healthcare system. So we're very excited about the work happening in the Medi-Cal program. The 2022 quality strategy, which really begins to embrace this, includes engaging members as owners of their own care as one of the 4 key goals, and includes transparency, accountability, and member involvement as a guiding principle. So that's number 2. Number 3, to talk on the strengthen the culturally and linguistically appropriate and responsive care that Sandra talked about. We have done a lot of focus groups, the Secretary alluded to this, with diverse consumers. And we continue to find that people of color, people with disabilities, LGBT people continue to experience stigmatizing, disrespectful, and discriminatory treatment at all levels of the healthcare system. And this has a profound impact on health outcomes. It discourages people from seeking care, and it creates harm to our mental and physical health. And it may not be intentional, right? We have many, many people in the healthcare system who are doing their best to help people and to improve health. But at the end of the day, we do need to diversify the healthcare workforce to better align with the communities served, and we need to implement policies that systemically interrupt bias. We're super excited about community health workers in the Medi-Cal program and beyond. I really believe that community health workers are not only culturally and linguistically responsive providers, but are also advocates for individual consumers and for transformation of the healthcare system. I just want to touch really briefly on behavioral health, and then I'll wrap up. So when we think about the separation of behavioral health care and physical health care, that separation is deeply rooted in inequities, right, historically and today. And people of color who seek behavioral health services often come up empty-handed, but even those who do find services are often not satisfied with the impact of that care on their personal goals and their life. So we do need more services, but we also need better services, and we need more integrated services. We hope that California will continue to embrace community-defined evidence practices, or those that are really developed and tested by communities themselves. But also, again, to the Secretary's points, that we will take additional steps to hold insurers accountable for the provision of behavioral health services. And just on that, in our research, we've found not only do consumers not know where to get their behavioral health services, but their primary care physicians don't know. Their own providers don't know, because that's how difficult the system is to navigate, and in many ways intentionally so. And so we really want to work on breaking down those barriers with that laser focus on equity. And so much more to say on equity, but I'm going to pass the mic along.
Thank you, Karen. Let me move to you, Louise, because really our FQHCs and our primary care clinics all across the state really are ground zero for so many of the things that Karen and Anthony, Cynthia mentioned. I wonder if you'll pick up on a few themes. One is payment reform, where I know the clinics are very engaged in that conversation. And then, of course, sort of the clinics pivot during the acute phase of the pandemic to telehealth and telemedicine, and where that is today in the clinics. And then, of course, related to that is just workforce and some of the workforce challenges, Louise. So I'll give it over to you.
Excellent. Thank you so much, and thanks to my colleagues here for queuing up a lot of the topics that I really want to underscore, in particular, pay for equity. I think that just, if we can have that just be the three words we walk out of here in, if you don't invest in systems, you can't expect them to be equitable. So just as a little bit of background, the Clinic Association of LA County, in LA, we've got 3.5 million Medi-Cal members, 113 health center organizations that serve 1.8 million Angelenos at over 400 sites. The majority of the patients they serve are on Medi-Cal, about 62%. A quarter, roughly, are uninsured. So when we're talking about coverage, we're really talking about Medi-Cal in LA. Other parts of the state, there's more take-up for health centers in covered California, private insurance, et cetera. But for us, it really is that focus on Medi-Cal and these expansions and thinking forward as to how this is the driver for everything in our safety net in LA. It's the main payer, it's the main coverer, it is what really makes our system happen. To that point, you think about payment reform and the connection with telehealth. Because the health centers have a per-visit payment system and telehealth had not been reimbursed prior to the pandemic, it was tough getting folks to invest and really implement those systems. All of a sudden, we get this declaration and we can actually pay our providers to do these services, suddenly uptick exponentially. And it was amazing to see all these folks on the fly implementing telehealth for physical, behavioral, you name it. They were moving to remote. It was keeping their providers safe. It was keeping their patients safe. And honestly, in a county like Los Angeles, where no one gets on the HOV lane, it was really helping out as far as the ability of folks to get to care, because it really is a barrier there. So not just in that piece of if you pay for it, they will come. Well, we are looking really deeply at reforming our payment system, and in 2024, there is going to be a cohort of health centers that are going to be doing things differently, and they'll be getting a per member per month payment as opposed to their per visit payment. But underneath all of that is the need to actually have an equitable payment system, because as it stands, there's a lot of stuff that the health centers are mandated to do. Transportation, you've got care management, care coordinators, all sorts of enabling services that aren't actually included in their rates, but they're mandated to do this. So we're rearranging the deck chairs on the Titanic a little bit here with our payment reform, and so we do seek to do additional reforms to the system. But additionally, beyond just health center payments, we've been doing a lot of expansions of benefits, a lot of expansions of coverage, but we have not increased the actual financing for our Medi-Cal system. When we think about all of these expansions, the 61 plus that Secretary Galley was talking about, our fee-for-service rates remain among the lowest in the nation. We think about, community health centers, there's a wide array of problems when they're in their payment system. Our hospitals, a disproportionate share hospitals are underfunded. Our Our enrollers are underfunded. I'm going to say, Kathy, we want you to get maximum funding for all of your people. We'd also like to see funding come down to the health centers. There's only 6 health centers in Los Angeles that are CHOI contractors. And those contracts go through DPH. They don't even go through our public and social services entity. So as we think through the way in which we finance this system, I want to advocate for all of us in the room that make up the safety net, the systems that get people enrolled, the systems of care, the health centers, of course, because those are my people, but we can't do it alone. And so we really need to think deeply about how do we finance the system. And so I'll just back up a second and reflect that we have an annual meeting of our members, all of the chairs of all of our roundtables. So the CMOs have a roundtable, the directors of nursing, HIT, and outreach and enrollment, health educators, you name it. If there's a common role across a health center, they have a roundtable at CCLAC. And so we got the chairs together for a meeting in August and said, okay, what are the cross-cutting issues that are coming across every single group, regardless of what their focus is at a health center? It was Medi-Cal and workforce. And they're inextricably connected. We can't recruit. The workforce is not there. There's not sufficient workforce there coming out and available. But additionally, the competition to hire them, we're competing against places where they can thrive, if you will. And I had to. And that's a challenge. We are honestly the pipeline program for a lot of the for-profit entities in the world out there too. So thinking through that, if we can't, we need to get access to more workforce. We want to see in the state budget more investments in workforce. Additionally, more investments in Medi-Cal. That MCO tax, putting that towards the Medi-Cal, actually, as opposed to general fund, focusing on that will allow us to, then our payment systems are associated with being able to actually recruit and retain more folks. So it's soup to nuts, whether you're a health educator, a biller, a coder, a provider, a mid-level. Workforce is beyond crisis. I think I'm previewing the next breakout session, Beyond Crisis, with folks, friends of ours on that panel. And if we don't, we need to focus in investments in workforce, but we absolutely need to focus investments in Medi-Cal so that we're actually changing the system.
Thank you, Louise. I want to come back, Anthony, to something that you mentioned briefly and really runs through the themes that we've heard already this morning, and that really has to do with costs and affordability. We have a nascent Office of Healthcare Affordability. Secretary Galley talked about transparency and accountability. I'd be interested, Anthony, in your thoughts on sort of what the hope is, what the vision is from your vantage point for the Office of Healthcare Affordability as we sort of both take on the cost issues and the new investments that are necessary that we've talked about through your fellow panelists here.
Yeah, no, I think we came, the many conversations that came to fruition on the Office of Healthcare Affordability, was with the struggle that so many Californians have with just a basic cost of healthcare and the frustration of it. And it's not just that healthcare prices are high, it's that they're also not for any reason then that actually is toward like the goals that we want for our healthcare system. Like the prices in the commercial side, and Louise is right to say that we also have this very strange mishmash of different payment systems that have wildly different rates for no real reason. And what the prices are that are charged in your typical healthcare setting are not based on the cost of care or the quality of that care or equity considerations with regard to the populations they're serving or the outcomes. They're basically based on like what is the relative market power of a provider versus a payer in the system. And in fact, that creates a set of sort of misaligned incentives throughout the system that are more about getting bigger than getting better, that are more about that are not served to do it. There's a lot of excellent people in our healthcare system that try to do good work, but like as the Crossing the Quality Chasm study for many decades showed that hasn't really changed. Your chance of getting the right care at the right time at the right place is sort of a coin flip, 50%, and we can and should do. And so when it happens sort of like because there's good people trying to work against the system rather than actually it as a result of the system. The Office of Healthcare Affordability is not going to solve all of that, but it's going to at least put another factor of can we look at the system as a whole, see where there's needs for a target that does not rise at multiple times the rate of wage growth or inflation, other places which might actually need more investment, and be able to do this in a more rational way that takes into account affordability and ultimately the patient experience of how they experience those things. So that's our hope, and we're excited about. We hope that any day now we'll get some appointments on the board. We look forward to the great work of the folks of the team that is being assembled at the new Department of Healthcare Access Information, and we think this is a really critical piece. And there's other states, Massachusetts, Oregon, others that have set up some of these cost commissions and have shown some actual benefit of modulation of growth, et cetera, to work with that shows some promise. And then we took it another step with regard to actually having, giving the industry both the flexibility and the tools to meet those goals, but also the accountability if they don't. And I do think that theme of accountability, runs through important. So that's, I think, one of the exciting things. And then we want to just make sure at the end, the last thing I'll just say is we want to make sure that this actually is how consumers experience this at the end of the day. And that means with both just the regular costs that they may feel with a premium or with their cost sharing, which I mentioned, but also with those surprise medical bills. We've done good work to try to remove the surprise medical bills with regard to doctors and ambulances and certain circumstances. Doctors and hospitals, the big gap is ambulances. We want to look at that. We want to also look at the fact of people who end up out of network because of inaccurate provider directories. And there's no place where those provider directories are more inaccurate and more frustrating, some people call them ghost directories, than in the behavioral health realm. So to tie into some of the other conversations we had. So again, that patient experience is really important.
Thank you, Anthony. All of you have mentioned workforce, and you can hardly imagine health equity, access, enrollment, without really recognizing just the extraordinary needs we have. Secretary Galley mentioned behavioral health, but really runs throughout our system. I wonder, Karen, CPEN's done a lot of work with community health workers and promotores, and that sort of ties into the sort of cultural humility and respect. I wonder if you'd talk a little bit about that effort. And Louise, I know, same thing. You've done some interesting things in the clinics on the workforce piece. Karen, do you want to comment?
Yeah, happy to. Thanks for bringing us back to community health workers, definitely one of my favorite topics. I think we are very excited that Medi-Cal will now be paying for community health workers and for the services that they provide, at least on the managed care side, and really see that as a huge opportunity to integrate community health workers who have been out there, been doing the work. We have community health workers in many communities. Some are part of our healthcare system, some are volunteers, some are your aunt, your mother, right? So we really have this incredible, valuable workforce that needs to be recognized and frankly treated with the respect that they deserve and really fully integrated into the delivery system. And so we are really focused on that. The state has set an ambitious goal of recruiting an additional 25,000 community health workers, which is very exciting, and really putting some dollars behind that. I think a couple things. One is really making sure that we create the economic conditions where community health workers can thrive. We have talked to community health workers who themselves can't afford health care, right, because of what they're paid in their profession. And so really making sure that we value the profession. I think also really making sure we provide that career ladder, right, so that we are really supporting our community health workers, both those who want to stay community health workers, right, and continue to promote within that field, as well as those who may want to train to be social workers or other types of clinicians. And then, finally, I think really thinking about all the different ways that we can integrate community health workers and other community-based professions, so mental health peers, for example, across our delivery system, and not keep them siloed sort of only in outreach and education, but really recognize the tremendous value that they bring is really going to help us extend our teams, extend our capacity, but also improve the care that we deliver.
And thank you for that. I would say, community health workers are fundamental. And I know I saw Maria Lemus here somewhere, so they're absolutely fundamental. And we saw that more than ever during the pandemic, when it was really that important need to have trust and have folks that were part of the community speaking to their peers and ensuring them that they could trust these systems that were providing vaccines, providing testing. And it's important to note, J.P. Morgan Chase a while ago did a study and found that in Los Angeles, healthcare is the largest source of middle-skill jobs. So if we think about those high school equivalency and up, and those are ladder jobs. These are opportunity jobs. CHWs are a place for folks to get an opportunity and to get connected to a healthcare system so that we're investing in the care to our patients and our communities, but we're also helping to elevate folks and bring them into a system and give them opportunity. And we've seen this time and again. I love, and I've really missed over the last 3 years, the opportunity to go out into the health centers as much as I used to, because it was always finding out where folks had started and where they were. Whether it was an AmeriCorps member that had been through our AmeriCorps program who's now directing a clinic, whether it was someone who started as a health promoter who's now a CEO, they're out there, and those stories are really valuable and important. And it's important to note that those stories have existed without the payments to go behind it for all this time, that health centers have continued to make those investments because it is important, it is fundamental, it does address equity for the patients and really bring up and elevate our community members. So we want to see continued investments. I think just these expansions are exciting, but we just need to, there's so much untapped potential in our communities that we can dig into more. And as we continue to invest in CHWs and other allied health professions, that's a place where we can really start to move the needle.
Great. This conversation's reminding me of our farm worker community, a community that has gotten a lot of attention as of recent with the gun violence that occurred in Half Moon Bay. And I'd encourage anybody with interest in sort of how do we think about our most vulnerable, how do we think about cultural competency, how do we get people into care. CHCF has a piece on farm workers that I think is very poignant and touches on a number of those issues. So let me just briefly plug that. It's on our website. I want to pivot a minute to, again, the Secretary referenced the Medi-Cal program as a tool for equity. And CalAIM is sort of our big, bold opportunity that DHCS and all of its partners have worked very hard and are really in the early phases of execution. And so, Kathy, I wonder, from a county perspective, what you're hearing, what you're seeing in the early days of implementation of CalAIM, and then I'll ask all the panel members to join behind you.
Sure, absolutely. So for County Human Services, I think the most immediate change has been the justice-related changes that just went into effect last month, which relates to ensuring that as individuals who are incarcerated are coming out and going back into the community, that they do so with Medi-Cal in hand, if possible. And so I think we started that work, years ago now, with the ability to suspend people's coverage rather than discontinue them when they went into jail or into a juvenile facility. That was something that started even before the ACA, and the ACA, I think, more formalized that, made it more of a national thing to make it clear that you can be receiving, you can be on the program even if you're incarcerated. The distinction then, which obviously we're now starting to meld, thank goodness, is you could not actually receive services that Medicaid would pay for, except in very extreme circumstances, being off-site of the prison or juvenile facility, admitted into a hospital, that sort of thing, and behavioral health under certain circumstances for juveniles. So what we've been working within is a structure where before January, this was an optional thing for county sheriff's departments and county probation departments to participate with the County Human Services Agency in helping let us know when somebody's incarcerated so we can do the suspension, let us know when they're coming out so we can unsuspend or find them eligible, help get that work. And then depending on the county, you might have county public health or the health department, county human services, or a CBO going into the jail or into that juvenile facility to help with the application process of the person. And so what we're seeing early on is it's going to be a little bit of a mixed bag. I think with 58 counties, you had some that already were largely doing this, some that weren't really doing much at all regarding the actual application process, since it was kind of a opt-in sort of thing. And so our folks are ready basically to do that work and to work locally. And so they're at the table, and the table is further or less far along. It did get slowed down a little bit by some grant funding. There was a first round of planning funds made available, and then a second round that was supposed to be, you could start applying for it, I think, theoretically originally last month, but that got delayed. So we're just now, I think, in the place where we're getting those applications. And so that's important. I think when we see the actual ability to provide and receive funding for those services while the people are still in, that is going to make such a tremendous difference. And I think in those counties where it hasn't moved as much so far with regards to just the enrollment part of it, that funding is, that's the carrot, right? I mean, if you're the juvenile facility or particularly the jails or prisons, you want that funding because you're providing those services. So I think you then have to get to the table and have that conversation and make sure that people are being found eligible. So I think we're going to see it really ramp up now that we've gotten that approval, which was so amazing. I will put me in the I was hopeful category, but I wasn't so sure we were going to get that 90 days. But it was really cool to see that come through. It's been a long conversation that I've been a part of.
So Kathy talked about the table, Kieran, and you've talked in your remarks about the power dynamic and who sits at the table. Any thoughts about either this new provision under the 1115 waiver, or in general about CalAIM and how we bring in voices of consumers to really help us rethink the system?
Yeah, I'll say we are also very excited, as Kathy mentioned, and to the sort of broader question of how do we bring in consumers. I'll say again, we're really excited about the work happening in Medi-Cal. It's just beginning, but I think thinking really broadly about how do we make sure that we're listening, that we're really listening to the people who are the users of the system, to our members, but also how are we giving them real decision-making power? And that's the part we haven't gotten to yet as a state, but really thinking about what is the structure, what is the governance, and the health centers really have the model for this, right, and really hold that up. And so, with their boards being 50% plus members, right? And so I think really thinking about all those different pieces across the healthcare system is important, because we don't only need to be listening, but we really need to be sharing that power in order to advance equity.
Louise, anything you want to add?
I think we need more data to be able to see where we're going and where we came from. I'm very excited to see, and we talked about the data exchange framework. We're bringing all these people through CalAIM. We're bringing, all these organizations, and they're all coming from different trajectories and all need different levels of support. So we've just seen a lot of shifts in how organizations are trying to step up to meet the moment and address the power dynamic in the system. And so the way in which we actually have to be equitable with the ways in which we're dealing with our organizations. Community-based providers are not all equipped to dial into the systems that they're now being asked to dial into. Similarly, some community health centers haven't done all of the things that they're being asked to do, and the way in which you're sharing data, there's an incentive for everyone to do their own system, which is really problematic. So as we think about this and power building and building equity for our communities, thinking about also how do we equitably address all the different CBOs, NGOs, community health providers, et cetera, and make sure that they're able to have an equal stake at the table.
Great. As we close, maybe I'll ask each of you to comment on, I sat on the data exchange stakeholder group, really had the honor to do that. And one of my big takeaways there is the forces for the status quo are very prominent, and they don't fade away easily, even when you have a North Star and you recognize that in the example of data exchange, so much inefficiency and waste in having fragmented data that's not shared when you're in a pandemic, who's gotten care, who's got a primary care provider, who's got a medical home. The forces for change are in this room, but not necessarily in all the industries in which we want change. And so I guess I'd ask each of you in closing one or two thoughts on how we overcome the systems that we have now that have incentives for profit as opposed for outcomes, that have incentives for protection of particular industry. What should we leave with in thinking about how we really bring together all the forces, commercial, for-profit, not-for-profit, community-based, to really be able to provide the kind of health outcomes that I think all Californians would be proud to be part of. So maybe I'll start with you, Anthony. We'll just work our way up. We've got a couple minutes before we close. So if people could be brief, that would be great.
I mean, the fundamental premise of my organization as a coalition organization is that, because often in the Capitol we try to work in coalition as a counterpoint to various parts of the industry, whether it be insurers, hospitals, doctors, drug companies, et cetera, sometimes allied, but sometimes in opposition. And so the question is, how do you empower that broad consumer, patient, public voice, which, when it is congealed, is more powerful. It can be more powerful than any specific interest, but the question is, how do you get that happen? And especially on something like healthcare, which for the average individual's experience is just profoundly disempowering. And Kieran is absolutely right. Whether it's communities of color, we host the LGBTQ HHS network, and certainly for that community, it can be. But frankly, for most patients, it is not an empowering experience to go through the healthcare system. But I think that's a critique that all of us share and can then demand better. And I think, and one of the ways to do that is, how do you deal with this, is to and how do you confront sort of like the powerful cynicism that people face when they are dealing with issues in general and healthcare in specific. And that's why I think it's a nice tie-in to how we started this conversation, which was that it is important to celebrate our victories. It is important to tell the story about how things were and what we have done, because as much as the work that we have done to expand coverage or to get rid of denials for pre-existing conditions or all the other things that are now history rather than current practice, I think even more so it's just the ability to communicate to people that progress is possible. And then, now you can't stop there. You can't say mission accomplished. This is in fact, you also need to sort of have a vision for where you're going. And I think the work that our esteemed moderator, Dr. Hernandez, and I and others did on the Healthy California for All Commission to get to what is a system that we want to be in is also incredibly important. So I think it's important to sort of show progress is possible and what we've done, and that hopefully eats away at the cynicism, builds the trust and then shows like a vision of what we can do. And that is the fundamental part of organizing that we all need to be part of to take these next steps in next year.
Beautiful. Kathy, briefly.
Yes, what he said. Also, I mean, it was a great way to put it, and I think when I was thinking about this question, because this one we had a little bit of advanced knowledge about, I actually was thinking about when I started at CWDA in the year 2000, which is a really long time ago now, and I looked up where were we in Medi-Cal. You know, it does help, right, like to go back sometimes and go, what was it like back then? We had 5 million people on the program. If you didn't have a link of some kind, a kid, a welfare case, a disability, you were getting on. And so over time, we've had stops and starts. We've had economies that weren't great. We had disagreements with leadership, people that we worked together with. Sometimes we'd fight with. I agree with all of that. And I think, so you just keep your head down, right? You just keep plugging away, eyes on the prize, and then every now and then you got to pop up and go, oh, and then when we did the ACA, we got 9 million people on. And we had 1 million people in the counties that we just dropped in with like one flip of a switch on day one. And that was amazing. And we had a huge fight over whether people should be required to provide proof of their address, which no one lies to us about. I'm just going to tell you. And we lost. We lost that fight with the Schwarzenegger administration at the time. And instantly there was a backlog of like 1 million people. Because guess what? That's a big pain in the butt. And so then guess what? The rule changed. And so we had to have the backlog for the rule to change. So sometimes even something that seems like a setback turns into the right thing for like us to keep making that progress. And I think when we were talking about healthcare reform back in like the early 2000s, there was all this talk about, let's bend the curve. I see Kim Belche, let's bend the curve. And I just feel like over time, what I've thought about is like, I think the curve does bend. I mean, it bends toward equity, it bends toward justice, it bends toward better pay, I mean, I hope, for all of the stuff that you're doing. It doesn't necessarily bend cleanly, and it doesn't bend every second that we're watching it, but you can look back and go, hey, the curve bent. And I think it did, and I think it will keep doing so if we just keep, working together and plugging away at it.
Karen, briefly.
Yes, I will be brief. So I think what I really think about is that we need to, I think, very bravely listen to communities and what we saw through the pandemic. So much of the innovation and so much of the resilience really came from far outside of our healthcare delivery system. And I think there's so much to be gained and so much to learn from our communities if we just listen.
Louise?
Yes, and celebrating our wins and the losses that we've avoided. I mean, repeal and replace was a near miss, and we really have to recognize just how much effort it took to get out of that. And it was people telling their stories. It was in Los Angeles, we had 1,000 health center staff and patients in the street on the anniversary of the ACA. It is about us sharing how these programs change our lives and moving the needle of every one-to-one person all around us. And it's individual stories, it's community stories, it's recognizing that we have come a long way, and you got to have some hope if you're going to continue to do just that Sisyphean task of pushing the rock, but we're going to do it bit by bit, and we'll get there.
Listen, celebrate, be humble, and keep pushing. Help me thank the panel, ladies and gentlemen, for a really nice conversation this morning.
Thank you so much to the entire panel, Sandra, Louise, Kieran, Kathy, and Anthony, always up to the minute and both hopeful and reasoned and grounded in the great opportunities before us. Please come up, our next panel. We know this is a long morning. Again, I encourage you to step up if you must, but also to stick with us for this great panel while we bring ourselves together. And then there's lots of opportunity for networking over lunch. So please come right up. Another fantastic panel. While we're getting settled, let me just make a quick plug for those of you who weren't with us yesterday for the pre-conference for the really excellent panels we had around CalAIM at that time. Again, a lot of insight around both the behavioral health issues and the opportunities of taking care of that on the ground. So, please, I would like to welcome our panel with just a tiny bit of context. As some have alluded to, and many of you know, over the past few years, ITUP has played a growing role at the intersection of healthcare and broadband. We're very excited about this next panel that's going to showcase state and local change makers working to connect every Californian with fast, reliable, and affordable internet and connectivity. Obviously, broadband and connectivity are important for communication and social interactions, but in the health domain, connectivity is also required for telehealth, virtual care, data exchange, and to leverage new and existing technology. So this panel is going to elevate some of the equity-driven work happening around the state to connect California communities. Moderating today's conversation is Sunny Wright McPeak. Sunny's the president and CEO of the California Emerging Technology Fund, a statewide nonprofit foundation whose mission is to close the digital divide by accelerating the deployment and adoption of broadband. From 2003 to 2006, Sunny served as the secretary of the California Business, Transportation, and Housing Agency, and previously served as president and CEO of the Bay Area Council. Sunny, thank you so much, and thank you to all our esteemed panelists. We're really proud to have you.
Thank you. Thank you, Miriam, and good day, ladies and gentlemen. What an exciting panel we just got to witness, and I appreciated that they got extra time. We're told we're going to go our full hour, so you don't get off the hook. As you just heard, I'm with the California Emerging Technology Fund. That is a really strange animal as an organization in California, in that the California Public Utilities Commission directed the establishment of CETF, they even came up with the name, California Emerging Technology Fund, as a public benefit out of mergers of telecommunication companies in 2005. And they literally just said, here is seed capital, the mission is go close the digital divide, but you need to spend at least $5 million on telehealth, which we did in starting the California Telehealth Network. We are a not-for-profit by directive of the CPUC, but by state law, report to the legislature. So we have this sort of extraordinary responsibility of accountability to the public. I want to just share with you our perspective on the digital divide. And just a little bit of terminology, the digital divide is the challenge. Digital inclusion is the process of addressing it, and digital equity is the outcome. We have known from the very beginning that the digital divide is just another manifestation of the economic divide, the opportunity divide, all rooted in systemic racism. And so if one doesn't understand why people are on the other side of the digital divide, we're never going to close it. And that's why CETF has been so excited to partner with ITUP. You know, it matters if you're providing a solution where people care. Technology is just a tool. If it's not used for health care, for education, for workforce training, it's not relevant. And so that's the way in which this panel is going to have a conversation about health and equity and why broadband. And by the way, broadband is just, in state law, a generic term for high-speed internet access. It includes wireline, wireless, should be performance-based, but it's just, again, a tool. Broadband's this general term. In our work with ITUP, we have looked at how do we get everybody online to take advantage of all the healthcare resources. So just as a way of gauging the challenge and doing a little bit of audience participation. By show of hands, how many of you here are either a direct provider or a member of an organization that is serving residents who are medically underserved or medically disadvantaged? I would guess most of you should have your hands up, right? Are you not? Do you know which conference you're in? Okay. I'm going to assume that the majority of you did that, although the lighter is sort of glaring. The next question is, so how many of you who are serving folks who are medically underserved know that those either patients or members are online at home with a high-speed connection to the internet that is affordable? Okay, I didn't really see many hands go up. That's the challenge that we're going to address with this panel, and that's why we're having this conversation. I've got the honor and pleasure of not only introducing all of these people, but actually working with them on a daily basis. They are among your champions at the head of the line in closing the digital divide and seeking digital equity in California. And so, just in order of how they're going to speak, Sean McKenzie is the CEO of Seneca Healthcare District. So he's on the front line when we used to have healthcare districts throughout California, providing the services to those that are medically underserved. The next gentleman to him, although I will tell you all 5 members of the Los Angeles Board of Supervisors, all female, by the way, are very, very powerful. It took me a long time to find this man, this is where the real power is, because Selwyn Hollins is the director of the Internal Services Department for Los Angeles County. The Internal Services Department does all the procurement. And so there's where he gets to negotiate everything around equity. I think, actually, Amy, you're next, you're going to be speaking next. But I'll introduce the gentleman between Selwyn and Amy. And you know him as the chair of the Assembly Health Committee. The Honorable Jim Wood represents the 2nd District, a very large district. It is the Redwood Coast. It goes to the Oregon border and down through Sonoma. You can travel his district for 6 hours and not be connected to the internet, which is an issue that we've shared for a long, long time. And then Secretary Amy Tong now is Secretary of the Government Operations Agency. Within that agency is the Department of Technology. Amy used to be the director of the Department of Technology. She was the state's CIO, Chief Information Officer. And in that role, she chaired the California Broadband Council. And it's when she chaired the council that we really started having traction and getting things done and bringing in all the state agencies and all the stakeholders. So it is my pleasure to get to work with all of these people. We're going to start off each with let's do about 7 minutes, if you can sort of do that, as to how you see the connection between health, equity, and how it gets enabled with the connections to the internet, or what we call broadband. So, Sean, you're on.
Sure, thank you. So this is my first conference where we're actually talking about policy. I'm usually on the operations side, so I thought operations was messy. You got a lot of work to do. I appreciate you. It's awesome. So I'm on the operations side. I'm the CEO of a hospital. My background is clinical, although 20 years ago I read Curious George Builds a Network and immediately figured out that IT is pretty cool, and I think that there's a connection, there's a confluence there between providing health and technology. So let's talk about technology. You know, we used to go to the hospital. Remember, we used to take the car over to the hospital, and that's where we provided care. And then we figured out that the hospital is not such a great place to go for many, many reasons. Let's do it to an ambulatory or an outpatient setting. So we moved into the outpatient setting. The care delivery model today is now we have to take it to the home. We've got to take it to where the customer is, where the patient resides, in a place of comfort, in a place of security, and provide care in a way that is meaningful, interoperable is the big thing. Interoperable, usable. You know, we have to have good data, but we have to have the information from that data, and we have to be able to share it. So to say that interoperability in healthcare that it is dependent upon a good broadband strategy or a good connectivity strategy is paramount. I don't think that there's a way to do it. Biotechnology, so biomedical engineering, we now have implantable devices, we have wearable devices, we have home health devices, we have all these things that provide us a real-time look into patient care. It's actual real-time. And using AI to take a look at whether or not we have an issue that's rising with a particular patient at their home is really critical to getting in front of the care delivery model. We've always, I heard it earlier, there was a speaker that's talked about the sick industry. You know, healthcare is the sick industry. Well, we're the sick industry because we refuse to get in front of it, or we don't have the ability to get in front of it. And I think broadband, frankly, is the keys to the castle in that regard. I work in an area in far northern California. It's very rural. It's a critical access hospital. It's a rural health clinic, and we provide care to our community, our entire community. And we have, in the north, we have extremely disenfranchised folks all throughout our community that have no access. They don't have a car. They can't come get us. They have no access to broadband, although we could extend out to them if we had that connectivity. It's such a disenfranchising thing as a healthcare provider to really want to reach out and take care of people proactively, getting in front of these things with no ability to do so. So I'll just stop there and you move it on.
Wow, Sean, wonderful. Selwyn, you're on.
Good morning. Thank you. I wanted to show a little visual just to kind of put it in perspective. So in the county of Los Angeles, we have over 416,000 households that don't have internet access at home. And so it is, for our Board of Supervisors, one of the top priorities. And so there's an initiative that was started in November 2021, and it's investments to accelerate digital equity. How do we take what we already have, the resources, the infrastructure, facilities, not only of the county, but partner organizations, hospitals, schools, libraries, public housing, to get people the internet as soon as possible? So the first slide I'm showing is the percentage of households in Los Angeles County that don't have internet access. This is based off of census tracts, and you'll notice there's different color schemes, but the darker colors or the reddish colors are where our census tracts where 20% or more of the households don't have internet. This only represents the urbanized parts of LA County. There's still northern LA County, which isn't reflected on these maps. I want to draw your attention to the darker red areas because that's what we're going to refer to in the next few slides. So remember, 20% or more of the households, those are households of roughly 3.7 people in the house or more. Okay? The next slide just focuses in on where that is. So these are the areas, as you can see, they're very congregated in the central part of Los Angeles. In Los Angeles County, we have over 1 million households that earn less than $50,000 a year. So affordability is a big issue when it comes to having access to the internet. This next one is the median household income. In the digital divide areas, the fuchsia or the reddish color areas are the households that earn less than $50,000 a year, and you can see the correlation to where the digital divide is. These are the same households that don't have internet access. This next slide shows percentage of households without health insurance. Obviously, the darker colors are larger percentiles. The reddish color is where 20% or more of the households don't have health insurance. You see a lot of the orange that represents 10 to 20% of the households. In many cases, and I can tell you in these areas, they're predominantly Black and Latino areas, but in many cases, these are historical, generational areas that are underserved and hard hit. In total, of the areas in the digital divide space, there's over 640,000 individuals that don't have health insurance coverage. And when we talk about the affordability aspect of it as well, where do you choose? Housing prices are very high in Los Angeles County. Medical care, internet, broadband, where do you make that decision? Transportation, education, clothes, all the basic necessities. Broadband comes into play in that. This next slide is an index that we used in the LA County the COVID-19 Vulnerability and Recovery Index. In Los Angeles County, we provide as a county many services to support the most vulnerable of the population. But COVID really emphasized all of the different areas that people need assistance from the county. And once again, you can see in the digital divide areas, those outline areas, has the highest need. And that's based off a variety of factors, from the U.S. Census Bureau's American Community Survey, the Office of Statewide Health Planning and Development indexes, et cetera. And so we look at what are the services that people need. Again, it's in the digital divide areas where people are hardest hit. And then this slide is the Healthy Places Index. You know, it looks at 25 community characteristics, healthcare, housing, education, et cetera. But the healthier the community, the higher the score. Once again, if you look at the digital divide areas, and those are those areas that are outlined, you can see where the greatest need is. And so as we have this conversation today, we're looking forward to tell you some of the things that we need to act on, all of us. We have resources, we have infrastructure to do things now. If we do it collectively, you'll be amazed. And I want to give a plug to Sunny on the Affordable Connectivity Program. So if you don't know about it, we need everyone who's eligible. In Los Angeles County, we have about 1.6 million households that are eligible. We have about 600,000 that are signed up. We got more to do. And so when we talk about being able to afford the internet, there are subsidies and other things that can assist people in getting this access. We have to get the word to them so we can help them, because these types of impacts aren't going away unless we collectively do something together. Thank you.
Director Hollins, thank you so much. And I want to just put everything in perspective that Selwyn just said. So these maps show the coincidence of the digital divide and the concentration of poverty, concentrated persistent poverty. When the federal government passed first the Emergency Broadband Benefit Program, which has now been succeeded by the Affordable Connectivity Program, which provides a $30 a month subsidy for low-income households who are connected to the internet. It's administered through the Federal Communications Commission. Its predecessor, when EBB was available, Director Hollins, at the empowerment of the Board of Supervisors, took on deleting the divide with great focus. And in the month of December of 2021, in 3 weeks, was able to increase enrollment in Los Angeles County in the Affordable Connectivity Program by 41%. I mean, when Selwyn puts his mind to it, he gets it really done. I'm saying that because we just did an ACP enrollment event in Compton. On Saturday, it was a festival that the Small Business Development Center was already doing, and so we were sort of augmenting it on. Of the 100-plus people who came to get to find out about ACP, not one of them had ever heard about ACP. So we've got an issue in terms of just notifying folks, and when we do in-person ACP enrollment, over 60% qualify because they're on Medi-Cal. So if you're on Medi-Cal or CalFresh or WIC or the National School Lunch Program or even Pell Grants in college, you automatically qualify. And I say that because I am going to go to the Honorable Jim Wood next, just in order, and then I'll go to Amy, because both of them are champions of getting everybody online. We need the state agencies to tell everybody who's on Medi-Cal that you're eligible. And I do want to give a shout out to the Department of Healthcare Services, because they are notifying all 8.5 million people as they roll out the information. And when those letters started going out, our call center had a jump of 4-fold in calls. So now we just need to keep reinforcing it, and the National School Lunch Program and the Pell Grants, et cetera. So Assembly Member Chair Wood, you're on.
Well, thank you, and good morning, everyone. Thanks for the opportunity to be here. My interest in broadband goes back to when I was running for the legislature. I remember driving through Trinity County. Trinity is a county in California. Okay, and seeing all this construction that was going on and wondering to myself, wow, are they putting conduit in the ground? Because the most expensive piece of the middle mile is that conduit and putting it in the ground. And we did some, Connie Stewart at Humboldt, at Cal Poly Humboldt, did some work and said, you know what, if you put the conduit in the ground, it's about $15 a foot when the trench is open. But if you go back and try to put it in the ground later, it's about $200 a foot. So I'm like, why are we not putting conduit in the ground? And so that was the beginning of my quest to get Caltrans to try to do that. And to Caltrans' credit, they are now doing that, but it has been a quest. We had a process in place to do that, went through multiple directors of Caltrans, and they kind of ignored it. But they are doing it now. And when you get to the middle mile network, there'll be several hundred miles that might be eligible for the Dig Once piece of that, which is significant. So as you heard from Sunny, I represent a really large rural district. It's almost 9 million acres. And when you take my district and my colleague to the east of me, Megan Dolly, the two of us represent 23% of the land mass in California. So it's actually 7 hours to get from one end to my district to the other, Sunny. And that's if you go north-south. Now, if you want to go east through Trinity County, that adds another hour and a half to get to the other end there. So I have a very, very large district. My district has the highest percentage of unserved people by population percentage in the state. And so if people wonder why I'm so dogged in my determination to get coverage, it's because of that. So, I've been focusing on working with other legislators to improve the mapping process. For one thing, excuse me. Might be a constituent in Trinity County calling me, I don't know. I'm trying to work on the mapping process, and Director Hollins showed, he showed census blocks and that show unserved and served areas. We want granular data to really help us understand what's being served. And because we hear, and I'll be honest with you, the industry doesn't want us to have that information. They fight us on that. And it's hard to get really accurate maps of who is served and who is not served. You can get the census block stuff, and they'll use that the other way too. It's like that census block is served because one household is served. It doesn't tell the whole story. So trying to get this granular data has been a quest, and we're continuing to do that. We had a bill last year. We have another bill this year which will enhance that. And it is such a difficult thing that the CPUC actually had to subpoena some companies to get the data. They ultimately have complied, and they're now working actively to try to build maps. And so it's a challenge, and it doesn't help sometimes when industry doesn't want to work with us on this. So it's frustrating as a legislator. So I've had a lot of my work is as the chair of the Health Committee. I'm now starting my 8th year as the chair of the Health Committee, and has been really about access, quality health care, and affordability. There's no simple solution to any of those. I've worked on legislation related to prescription, or trying to bring prescription drug costs down, PBM, transparency, the role of health corporations. We were successful in California in stopping surprise billing in 2017, and it took the federal government 5 years to catch up to us in California. That just happened. So what we do in California really does matter on a national level. And we've worked really hard on the subsidies for Covered California, getting more and more people, like some of those million people in the LA County that don't have coverage at all. So I'm also very concerned about consolidation in healthcare. I don't think that's necessarily a good thing. It can be, but it often leads to higher prices. And we talk a lot about CalAIM here in this conference, and what a big deal that is. We've held multiple hearings on CalAIM throughout the process. I understand also you're talking a little bit about health information exchange, which is a really, really big deal, something we've also been working on. So one of the things that I am most proud of is our work on the Office of Healthcare Affordability. That office, working with the governor's office for two plus years to get that across the line. We'll collect information needed to identify healthcare costs and then finding ways to create enforceable cost targets. I think that will be a huge step forward, and it's going to take a little while for that to come into play. I want to hit on, and then I'll stop because I've got a lot of notes and I could go on and on. But one of the challenges for us is I look at broadband for three distinct reasons. It's really important in education. We saw huge challenges during COVID related to that. It's really important in our business communities for economic development. And then finally, and most important to me, is access to health care. So my focus is and always will be on getting access. I recognize that people want affordability and they want improved access, but we don't have access in our district. And when Sunny was talking about the travel and how the lack of access, it's real. I have kids working on college applications. They have to go sit in the parking lot at a library to access Wi-Fi at night to do college applications. Now, that probably happens in a lot of areas in the state, but you might not have to drive 25 miles to do that. And those are the kinds of challenges that we face in rural California. So I know we'll have questions and more time to elaborate, but thank you for the opportunity to start out here.
Thank you, Assemblymember Wood. Okay, the Honorable Secretary Amy Tong. You have, I know, remarks, but also I just want to acknowledge that as chair, you really did focus in on how do we accelerate closing the digital divide, chair of the California Broadband Council. And so, just also reflect on what can be done, and especially how all of the audience and how all of us can help you and the legislature in the work you're trying to do.
Yeah, thank you. Good morning, everyone. Great to be here, and thank you for having me as part of the panel with this so many great ideas already being shared as the kickoff of this panel. I'm going to take my opening probably slightly different because I've heard, from all of our panel members talking about from the policy side, the operations side, the need, and of course, Dr. Wood, I'll call him, given that we're in the health fair today, how, he literally, I've kind of vouched for him for somebody that have the conviction that you need to make some of these policy change and driving and just, holding people accountable. Definitely, Dr. Wood, it's up there. As I have a privilege of serving with him on the Middle Mile Advisory Council of the state. But in my role as a Secretary of the Government Operation, what does that really mean? I'll give you 3 examples on where broadband and healthcare really intersect. And speaking from those examples, you can hear, I hope you can also share and understand why having a broadband as a basic infrastructure, it would go a long way to bring the equity that we've been talking about to every single resident of California. Just as yesterday, I was in a tribal nation summit with the governor, along with all of my cabinet secretaries, meeting with over 500 tribal leaders, talking about their needs in terms of what the state of California can work with them on. The number one ask and the number 2 ask in that conversation in the entire day, guess what it is? Health and broadband. And it's the bookmark of the various issues that they're being brought up. Why is that? One, people can think about, well, first of all, where a lot of the tribal reserves land is rural area. And in Dr. Wood's district, 3 of the 4 major tribal nations are in that area. 2, because it's in rural area, the underserved, it's an understatement, right? So what do we need to do? And aside from the fact, great, let's lay the infrastructure, let's get all of the connection there as much as possible. Many of them even talking about the lack of access to power. So that's a whole nother realm that needs to be solved. But what is the impact to the community when you are systematically disconnected from everything else going on? one of the statements that was shared by one of the elderly tribal leaders in there was just really touching. She said, in the health arena, not so much of access to the clinic. If somebody really gets sick, from a physical illness and all that, great. They have access, they take people to the hospital and all that. But mental health is one of those areas that they have seen way too often. It's too late by the time they discovered that they were not able to get people the help that they needed, because they ended up spending more time, and I use this word in a very sad manner, recovering the individual, as in they have already passing on, as opposed to having some type of a prevention through a digital connection, so that without having to leave their home, which affects many of the elderlies, they miss out on the opportunity that potentially having some type of a telehealth opportunity in front of them to receive the necessary help when it comes to a mental health illness. That's one example they talked about, that they really, really want to move from recovery to prevention. Second of all, as you know, at the beginning of the year, really at the day that we were about to celebrate the Lunar New Year, as an Asian American, one of the Asian American leaders in the administration, instead of helping the governor with some congratulatory statements about the starting of the Year of the Rabbit, I was there helping him putting on talking points about the Monterey mass shooting. Within 48 hours, the Half Moon Bay shooting took place. One of the unfortunate commonality, both shooters were elder Asian male. On top of that, they probably have language barrier, which in a Asian community I know is not unique in the Asian community, that also getting access to help with mental illness is a stigma. Not only that, the availability of those services to the community was also not that readily available, because the way that in many cases people do not think they would need such help, or they were afraid to get such help, or they were ashamed to get such help. But imagine if there were more ability to reach out to them, whether you call it digitally or other methods, as knocking on the door, as Sean has mentioned, is getting that care help to their home. Maybe at the beginning, and once they become more comfortable with it, they can use their phone, they can talk to people, they can get access to help in their native language, with the people that look like them, so they feel comfortable talking to them. Perhaps, and I know that's a big perhaps, some of these mass shootings could be prevented. Lastly, just to bring it home even more, speaking from a personal experience, talking about telehealth, my mom has been fighting cancer for the past 4 years. She recently passed away last June, succumbs to the illness. But in her final months, there was just a lot of care that she needs, and that also took place right around the time COVID was running rampant. 2020 and 2021, we cannot leave home. We cannot take to the hospital for a checkup. If it wasn't for the fact that her house and my parents' house had a good internet connection, they had a good access to mobile device that, continued to keep her going with a regular checkup through a telehealth, her lifespan probably would be further shortened to the fact that due to, good care. And during that time, also, she was able to get access to folks. And for a moment that you remember that time, like nobody can see anybody, even me being a close family, I had to call her on the phone, talk to her regularly just to keep her spirit up. So all of this, what is leading up to, I know there's a lot of conversation on what do we need to do from a policy level, what do we need to do from an implementation level. My job in the administration is bringing this home. What do we need to do really make this work going forward and see the results from it? But it's because it's that important that each one of us one day, if you haven't already, will experience the need or the negative impact if you don't have good access to healthcare in a digital manner.
Thank you, Secretary Tong. Let me build upon what you have said and Dr. Wood. in terms of how broadband can enable access to health care and equity, and just share a statistic that was quite sobering to me. In late 2020, when the pandemic had hit, the California Emerging Technology Fund with CENIC and partners in CARE Foundation and the Primary Care Association California convened about 12 hours of listening sessions, listening conferences with every segment of the healthcare industry. And the federally qualified health centers testified to the following with respect to behavioral health or mental health appointments, that they would typically experience a 30% no-show when they were able to go to telehealth. For those of their patients who could get online, they had 0 absences, 100% show. I mean, just your comment about can we do prevention as opposed to recovery, it was just telling to me that the FQHCs were saying that about how telehealth could be helpful. So that's number one. Number two, you talked about the tribal leaders. I think many of you know California has more federally recognized tribes than any other state, 109, and there are more that aren't federally recognized, and we have more Native Americans who live in California than any other state. Our tribal lands tend to be the most farthest out. So now I'm going to jump off into we need telehealth, we need everybody to be connected. Sean gets to bring up the point of how we're going to do this. Many of the providers out here want to know how their facilities actually get on a high-speed internet connection, let alone that Selwyn's got 10 million, a quarter of the population in Los Angeles County, and he needs to get everybody connected. We have been advocating for let's drive to the tribal lands, the hardest to reach, rural, and also the hardest to reach in urban, high poverty. Deploy with our dollars out to those hardest to reach, and then connect everybody along the path of deployment, which would pick up everybody in this room. What can we do to get that adopted and embraced as the way we use all the federal dollars we're trying to deploy today? So let's start with you, Amy, and then Jim, and then just come down the line here.
Right. Probably not many of you are tracking what's going on with Middle Mile, other than me and Dr. Wood here, and Sunny, of course. But one of the strategy that the state has in the middle of is that due to the support of legislature and Governor Newsom, was it 2 years ago already? Time flies. Almost a year and a half.
2 years.
2 years.
Time flies, and even if you're not having fun.
That's right. Almost 2 years ago, $6 billion as a historic investment was made in California to build a Middle Mile network, and 3.25 of that is for the Middle Mile network. I think it's a 10,000 mile is what we ended up with in terms of the mapping, plus more work or more funding is available for the last mile in order for that connectivity to become a possibility. And the work that is undergoing right now, the Middle Mile map that is posted at the California Broadband website, does show to the extent possible north to south, east and west borders of California. Take it as rural as possible so that public infrastructure is available for a lot of the local provider. It's probably I shouldn't say local provider. A lot of the service provider to connect that last mile to it. The beauty of the last mile approach is not all construction, right? We are looking for industry partners where if they have already implemented middle mile, but may not have turned it on for various reasons, we call those the dark fibers. Let's talk. Let's find a way to lease some of those lines so we can accelerate the possibility of completing this 10,000 mile. So with a combination with working with Caltrans, as Dr. Wood mentioned, whether it's through the DIG-1 policy or any opportunity that we can go to build a last mile if there isn't one already, as well as working with the industry to see if we can partner with them either to lease or co-joint to build, to accelerate some of these, we're taking all of the tools out of the toolbox to make sure that the basic infrastructure of the middle miles can be completed and in time, so that therefore the last mile providers can get the last mile. Now I'm repeating myself. I use the last mile as the local street in Cleveland to connecting the I-5, the 99, or whichever the highway. That is the complete infrastructure that is needed to make sure that connectivity is bringing to everybody's home.
Thank you, Amy. I'm sure, Jim, you would. I'm almost ready to get a shovel and start digging on 101 and 1 myself. And 299, I think, is actually now under construction. But, it's obvious even I can look at a map and say, where does it need to go? How do we accelerate the progress, sort of bend the curve more rapidly to justice?
Well, I think the middle mile project is really key. And there's a push and pull with my colleagues sometimes is that, I tell people, I've said this for years, you all were asking for 5G capacity, and I just want 1G. And you laugh, but it's the reality of what we're dealing with here. And so I get that the illustration there's a push and pull of this $6 billion that people who actually have access to high-speed internet want better access, while we in our communities do not have access at all. And so the biggest thing that could go wrong here is if that in the end people get faster access and we don't get the access and continue to be left further and further behind. So that idea of going to the hardest to reach communities and focusing on them and building out from there and connecting along the way is a great approach. I love that approach. And it takes commitment, it takes time, and it also it's tough to fight against. I'm one member who represents 5 counties. 27 of my colleagues represent part of Los Angeles County. Mm-hmm. So how do you think that usually works out? It's challenging. But I learned in the healthcare space that when you talk about access to healthcare, we have huge challenges in rural California, but there are huge challenges in urban areas as well. There are pockets throughout urban areas, and once we figured ways to collaborate together with my colleagues who have those same kinds of challenges, there's a synergy that happens. And so I focus on working with them to get their needs met, which are the same as mine. And if you all got high-speed internet and you want it faster, could you just wait a little while longer? Because those of us who don't have it would really like to catch up.
Thanks, Jim. Director Hollins, I think you're set up. You are for Los Angeles County representing a third of the legislature, and many of the low-income, high-poverty communities that might as well be in Del Norte, quite honestly. And I know all 58 counties. I love every community once I get there. Selwyn, how are you accelerating the deployment to the hardest to reach?
Yeah, it's a real challenge. I know Assemblymember Wood has a bill that we're supporting. The recent priority maps of the federal government and the state.
Throw out the maps.
Yeah, they don't cover any of Los Angeles, city of Los Angeles. We have 88 cities in the county, and most of the historically underserved are not part of that funding scheme, which means hundreds of thousands of households are going to continue to be without. And so what we've done in Los Angeles County, and we're talking with other cities and states across the country, is how do we leverage what we already have and support one another? So, for example, in Los Angeles County, the 2 biggest organizations are the county and the city of LA. Historically, we each compete for the same grant dollars. Well, we've entered memorandums of understandings where we won't do that. We will share our assets. We will share going after grants together because it's the same population we're trying to serve. We've established similar MOUs with the Los Angeles County Office of Education, which represents over 80 school districts. We are working with some of the healthcare clinics and agencies in Los Angeles County to also establish MOUs. Many of the healthcare facilities are great anchors. All the terabytes that go through a hospital or a clinic are off the charts. In the county of Los Angeles, for example, all of our schools and all of our libraries are equipped with fiber. But because of E-rate, the E-rate requirements was a whole nother discussion, unless it's an emergency, they can't extend out from the school and use that infrastructure. So we have to request funding to build a separate infrastructure when there's one that already exists. So you can go to school and have access, but you walk down the block 3 blocks and you don't. Okay, how do we change that? We can't change it by arguing the same points. We have to argue a different argument, but collectively. So what we've been working on is really how do we align all of these agencies, jurisdictions, hospitals, libraries, together and speak with one common mission. And so what we've done is we started this a few months ago to accelerate digital equity. We are going out with public-private partnerships to provide community broadband networks in some of the hardest hit communities. We do a pre-qualification process where they will guarantee low prices or free service for up to 5 years. And this would cover the entire area, but we provide our assets to help lower those costs. Many of our facilities aren't going anywhere. Many of your clinics and hospitals aren't going anywhere. They are part of the community, yet being able to use those facilities without any cost to you in order to enable broadband to spread out to the surrounding community is very important. We've released 2 work orders in January. The first area is South Los Angeles. The area we're trying to cover is the most historically disadvantaged area of Los Angeles County. There are, I believe it's about 46 square miles, 190,000 households that would be in this coverage area, and of those households, 40,000 don't have the internet at home. The second area that we released a work order for is East LA Boyle Heights. It's roughly about 36 square miles. Again, over 100,000 households that are impacted, and about 20,000 that don't have the internet. The people in the community can still stay with their internet service provider, which is in many cases just one provider. Okay. There was another report that showed people in these communities paying twice as much as more affluent communities. Okay? We're just saying, hey, we want to make sure people get access. And let's be honest, everyone needs health care. From the time you're born until all your days on this earth, everyone needs health care. But when you have hundreds of thousands of people that can't get it when they need it, it's a problem, and we have to work together to solve it now, not later.
All interesting, really interesting. I think that funding the Golden State Middle Mile that's a done deal. So that's the middle mile. We have a bigger problem. It's the topology and the infrastructure supporting last mile. How does that get built out so that it actually reaches the home, whether it's in the air or in the ground? I was thinking about, as we were going down the panel here, about the word consolidation came up, and I really want to hinge on consolidation from a care perspective, from a continuity of care perspective. We talk about the data exchange framework and HIEs. I'm just noodling out loud. I'm probably going to be booed by my constituents at home, but there's money available if we take a look at as we consolidate. Let's not consolidate care into care places. Let's consolidate data. Data is what needs to be consolidated, and because the capability of exchanging data and using high-speed broadband from the home to the hospital, whether it's critical access or safety net or an FQHC, is irrelevant. Bringing the data in and then moving that data down the path to higher levels of care, to places of excellence. And that data is available to all. And then let's take a look at the replication and duplication of procedural work that is done at every facility along that pathway. I can send a beautiful CT across the wire to a higher level of care in support of a patient's continuity care. I guarantee you they replicate it. I guarantee they duplicate that CT. They do it again. Why? Because they can bill for it. They can charge for it. And they do. We all do. We all sit there and twist our mustaches and figure out how we can bill. I think that there's money there, there's money available, but the consolidation must be something that's driven by policy. Data consolidation is driven by policy. It's not going to be driven, we talk about our partners in healthcare, and I'm one of those partners in healthcare. I have a little different perspective because, to me, care is the whole person. It's irrelevant where they go for care. But consolidating the data, I think, is the critical piece of that. That requires an infrastructure all the way to the home. And then I think that there's money there. We'll find money there when there's less replication and better continuity of care. So I'll just stop there.
You don't have? Excellent. So I think let's talk about it. You can't consolidate data if everybody's not connected. The data, the infrastructure, the high-speed internet infrastructure actually enables the sharing of data and the consolidation of data. I do want to say that we've had a great partnership with ITUP in promoting the Affordable Connectivity Program. So we want to continue that as everybody has discussed here. Congratulations to Crispin Delgado from Richmond, California, the county where I was a county supervisor for 16 years. So we want to work in that area, and we also want to optimize telehealth. That's why the California Emerging Technology Fund is sponsoring Telehealth for All. We just need an author, but we're sponsoring a bill, but we still need to get an author. Now, I'm going to quickly tell you a story. Years ago, I was the director of the Tiburcio Vasquez Health Center, and it was still just one little trailer that we had, a portable. Today, it's multi-site, really sophisticated as a federally qualified health center. And recently, CETF received the only grant in California for telehealth equipment from the Federal Communications Commission. Our Director of Telehealth and Human Services, Leticia Alderez, is here. Leticia got every last dime spent of that money, and the last partner we went to was Tiburcio Vasquez. They really were anxious to have the telehealth cards, and Leticia will tell you, so we did that. But now the real effort is, how do we train people? The carts have to get connected. There has to be high-speed broadband. We have to actually have the infrastructure that is human for people to be able to connect to not only their patients, but if they're going to do a referral to a specialty provider at a medical center, are the protocols in place? If I'm going to send that CT across, is someone really going to be available to me as that health center, community health center, to read it and not do a double billing? So how do we quickly, down the road, optimize telehealth? How do we get telehealth for all? What policy do we need in this state to achieve it?
A good broadband policy would help. We'll just start there. Okay. Yeah, so connectivity. I think that incentivizing telehealth, we have done a good job of being able to bill for telehealth and those services. I think that the pandemic was very revealing. I thought it was an excellent example of what can be done when there's a reason to get it done. And it's starting to flow away to the old paradigm. I think that we need to remove. It's a long driven in. It's very deep. It's the scarcity paradigm in healthcare. I call it the scarcity paradigm. There's only just enough to give you, even when you need it. I think that we need to shift to more of a synergistic paradigm, which means that we are all in this together, which means all healthcare providers along the chain, regardless of size or complexity, it's irrelevant. That the synergistic healthcare mindset and philosophy puts forth technology enablement. It brings that ability to draw bridges and bring things and consolidate data around a patient. I think it's wrong that patients need to be responsible for their data. I think it's our responsibility for their data. So I think incentivizing telehealth and the use of telehealth in the continuity of care by switching mindset around synergistic care, not scarcity care, is a good step forward.
Yeah, I would say from a policy perspective, one of the challenges is how do you operationalize it? There's a lot of studies, there's a lot of ideas, but then once you develop that blueprint or you pass those legislative acts, how do you operationalize it? The people in the community don't have the ability, so there needs to be a nexus for those things so that it can come to fruition. And it shouldn't necessarily be based off of each group going out trying to figure out their own way to fund it. There should be a way that it aligns so that when a decision is made, a law is passed, you have reassurance that it's going to reach the people it needs to reach.
Great. Dr. Wood.
It's a battle. It's a battle to continue to fight for a lot of these things, and I think it's going to be battle by battle. Health information exchange, for example, some of the biggest barriers to that our large healthcare providers. Didn't want that. Didn't want that to happen because they didn't want that information to be freely available to other systems, to the detriment of the patient, to the detriment of overall healthcare. Internet carriers, broadband carriers don't want some of what we're doing to happen because they don't want the competition, yet they don't provide the service either. So we have to work to find ways to break down the barriers, and that's where it's a battle. It's an absolute battle. And I will say one thing here, and it's and real quick. When you talk about access to mental health care through telehealth, I have a family member who's been able to access that, and it's been really, really helpful. It's been absolutely wonderful. But 50% of the people in my district rely on federally qualified health centers. And you still have to if you go in for a visit, and then you decide you need a mental health visit, you got to come back. You got to come back. And for some of my folks, it's hours to get there the first time. And once again, a barrier that we've got to find a way to break down. So we just keep fighting battle by battle. It feels like all quiet on the Western Front or something, sometimes. So trench warfare.
All right, I'll do it really quick to wrap up this topic. During the COVID response time, which I was also part of for the 2020 until most recently, one muscle that we all built is don't overthink things. Simply, we don't have time, right? All the customization, all the tailoring that everybody wants, every T's to be dotted, or every T's to be crossed, or I don't even know how to do it because I don't do it that way. We got to move forward. I think many cases people are trying to find a perfect solution, which is the solution would never come. So what I would do, recommendation, and if this is the part that we need help from everybody, is change the mindset. Is willing to take some intelligent risk, go iterative, start putting some of the things that we wanted to do into practice, and just try it. It's okay. Probably 50% of the time the outcome's not what we want. Don't worry about it, right? Keep trying, keep moving, because if you don't do that, the risk of not doing anything is worst. And we know that also COVID have taught us we have to get the services where people are. We cannot build something and hoping people will come. Those days are over. People have the rights. As long as we can provide the infrastructure, this is why broadband is critical, to bring the services to them, and with the mindset, the more prevention service you do, the less recovery that you have to do towards the end. And that, to me, is so fundamental to how we bring equity and how do we really provide a user-centric services from a public sector. And that's where I'm speaking from, of course, from that voice. And if that could be an influence to the industry as well, to those, whether it's healthcare or telecommunication, at the end of the day, we are all have an obligation to serve our residents in California.
Thank you. So as you just heard from Secretary Tong, don't overthink, and from Chair Wood, trench warfare. I actually think those are really good calls to action. And what I think should announce on behalf of Secretary Tong and Assemblymember Wood is that there's a big planning process for digital equity plan that was authorized by the legislature but also required by the federal government, and a plan that's broadband equity access deployment. There will be a meeting in your area, 20 throughout California, and we want everybody to be here. ITUP will send out the information, tell you where to go, because that's where you don't overthink and you demand in a trench warfare way how to get access. And Connie Stewart wants you there on Friday, March 24th, Jim. So I'm delivering the message from Connie. You mentioned her because that's where one of those forums they're trying to plan would be. You heard from Sean, we need a good policy in California. Part of that is telehealth for all, by the way. I'm going to put that plug in again. The second is get all of your patients, members online with the Affordable Connectivity Program. We, CETF, have a table here. Rebecca Barrett and Nadine Hugg and Leticia Alejandras will help you with information about how we can assist you in enrolling everybody. And if you take the kind of focus that Director Hollins has had in LA, we can get this job done. So don't overthink. Focus on getting the job done. Get good policy. And remember, we're always in the trenches on behalf of health equity so that we can have community justice. Thank you, everybody. Give the panel a round of applause.